Good morning, everyone. I'm Jennifer Walsh, a Senior Media Officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us here this morning. We have some folks here in the room as well as a number of folks joining us via webinar. This, again, is a public briefing for our recently released report, A National Strategy for Elimination of Hepatitis B and C Phase 2 report. You can download a copy of the report and other supporting materials right now, including today's PowerPoint slides, at www.nationalacademies.org/hepatitis elimination. And you can also follow the conversation about the report on Twitter at #hepatitis elimination. For those of you not familiar with the National Academies, we are private, nonprofit institutions that provide independent, objective advice and analysis to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. The National Academies operate under a congressional charter of the National Academy of Sciences that was signed by President Lincoln in 1863. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study's statement of task. The reports that result from this study represent the consensus view of the committee and must undergo external peer review before they are released, as did this. For today's briefings, we'll start off with opening remarks and a summary of the report, and with the remaining time, several members of the committee that wrote the report will answer some questions from those of you here in the audience and those of you online. So please note that this briefing is scheduled to last for 1 hour unless we run out of questions beforehand. Lastly, before I introduce the committee, I want to go over a few technical aspects of the webinar for those of you joining online. After the opening remarks, we will begin to take questions through the Q&A box located in the lower right-hand corner of your screen. Simply type in your question in the box at any time and click Submit. We ask that you leave the box set to send your questions to all panelists. If you have any technical issues during the event, please contact WebEx Technical Support at 1-866-229-3239. Once again, that number for WebEx is 866-229-3239. And with that, I'd like to introduce 7 members of the committee that we have here today. First, I'd like to introduce Dr. Brian Strom, Chair of the Committee and the Chancellor of Biomedical and Health Sciences and the Executive Vice President for Health Affairs at Rutgers University. Next, we have Dr. John Andrus, Professor and Senior Investigator for the Division of Vaccines and Immunization at the Center for Global Health at the University of Colorado. Also joining us is Shrutu Mata, a Professor of Epidemiology at Johns Hopkins University. Also from Johns Hopkins University, we have Dr. Stuart Ray, the Vice Chair of Medicine for Data Integrity and Analytics, and a Professor of Medicine at Johns Hopkins Bloomberg School of Public Health. Next joining us is Dr. Samuel So, a Professor and the Director of the Asian Liver Center at Stanford University School of Medicine. Also joining us is Dr. Niraj Sood, the Vice Dean for Research for the Schaefer Center and a Professor at the Sol Price School of Public Policy at the University of Southern California. And also is Dr. Grace Wang, a family physician for the International Community Health Services in Seattle. And I'd also like to introduce Dr. Jillian Buckley, who is Study Director for the National Academies for this report, and Dr. Rose Martinez, who is the Director on the Board of Population Health and Public Health Practice here at the National Academies. And with that, I'd like to turn it over to Dr. Brian Strom.
Is my mic live? Mm-hmm. You can hear me? So thank you all for joining us. What I'd like to do is going through the PowerPoint that you'll have access to, give you a brief overview of our report before opening up for questions. So the report, again, is a national strategy for the elimination of hepatitis B and hepatitis C. I'm going to briefly go through the statement of task, the public health significance of hepatitis, the targets that we ended up choosing as part of it, the target reduction we ended up choosing as part of the report, and key information, key sections on information, intervention, service delivery, financing, and research, and I'll define each of those and chose them in the order we chose them as I go through. First, the statement of task. This is a 2-phase report. Phase 1, the question was, is it feasible to eliminate hepatitis B and C from the United States? And our answer, briefly summarized, was essentially yes. but not likely without attention to serious barriers. Here in the Phase 2 report, we look at what exactly is the strategy to eliminate viral hepatitis from the United States. In other words, how do we address those barriers? First, I want to give some background about the public health significance of viral hepatitis. Chronic hepatitis B and hepatitis C infections affect 3 to 5 times more Americans than HIV. Worldwide, it's 10 times more. Viral hepatitis kills more people worldwide every year than HIV, road traffic accidents, or diabetes. Yet despite being the 7th leading cause of death in the world, viral hepatitis consumes less than 1% of the NIH research budget. 1.3 million Americans have hepatitis B, 2.7 million have hepatitis C. Hep B and Hep C account for about 80% of the world's liver cancer, and chronic hepatitis B increases the odds of liver cancer 50 to 100 times. Hepatitis C increases the odds of liver cancer 15 to 20 times. So viral hepatitis is driving the 38% increase in liver cancer in the U.S. that we've seen between 2003 and 2012. While most cancers in the U.S. are decreasing in incidence, liver cancer is increasing, and these two diseases are the primary reasons. What has changed? Why the attention nowadays on hepatitis? There really has been a dramatic change in our armamentarium to be able to address this problem. There's an effective vaccine for hepatitis B, and now there are new treatments that can cure the vast majority of hepatitis C patients as well. Treatment of hepatitis C is expensive, and we'll talk much more about that, but it is still cost-effective compared to other interventions. So though it's expensive, its efficacy is so high that when you look at its benefit compared to its cost, it's actually quite reasonable compared to much of the rest of what we do in medicine. It is possible to eliminate hepatitis B and C in the United States, and we'll talk more about strategy, averting in the process about 90,000 deaths between now and 2030. This report is a roadmap about how to get there. So in 2016, the World Health Assembly passed a resolution to eliminate viral hepatitis by 2030. Member states were asked to develop national strategies for elimination, and I'm happy to say that with this report and its aftermath, the U.S. will hopefully be the first of those member states to achieve that. Each national strategy was asked to consider 5 strategic directions, and this is the order that you'll see in our report that I alluded to before. Strategic direction 1 is information for focused action. Basically, what do we need in order to be able to do that? What information do we need in order to be able to achieve this goal? The who and the where. Strategic direction 2, the interventions for impact. What are the things we need to do in order to be able to have this beneficial effect of eliminating viral hepatitis? And again, here the question is the what. Strategic direction 3 is delivering for equity. How do we actually, or the how do we get these interventions to the people who need them? So it's not only a question of identifying and developing the interventions that are now in place, but we need to make sure they get distributed and used in all the places that they are needed. Direction 4 is financing for sustainability. As we alluded to, some of these interventions, particularly the treatment for hepatitis C, is very expensive. How do we develop a mechanism to be able to afford that? And strategic direction 5 is research. What are the things we need to do in the future so that we can continue to advance these goals in the future? Our hepatitis, we went through a detailed modeling exercise for each of the 2 diseases. For hepatitis B, we felt that a 50% reduction in mortality from hepatitis B is possible in the United States by 2030. This would avert, in and of itself, 60,000 deaths. Meeting this goal would require diagnosing 90% of those people who have chronic hepatitis B right now, most of whom are asymptomatic, bringing 90% of those to care, and treating 80% of those for whom treatment is indicated. The same level of diagnosis, care, and treatment will also reduce new cases of hepatitis B-related hepatocellular carcinoma by about 1/3, and new cases of hepatitis B-related cirrhosis by about 45%. So again, there's potentially reduction of 60,000 deaths, a dramatic increase, a 1/3 decrease in liver cancer, and a reduction in Hep B-related cirrhosis by about 45%. That's just with hepatitis B. The elimination of hepatitis B virus infection in neonates and children under 5 is also possible. That wasn't demonstrable in our modeling, but we've seen that because it has been achieved in Alaska natives with interventions now that have been done in Alaska. In terms of the results of our modeling in hepatitis C, we think that a 90% reduction in incidence of hepatitis C can be achieved by 2030. That's 90% reduction relative to the 2015 incidence. And with this new technologies, we've already been very successful in the last few years in reducing, already having impact on reducing incidence. But meeting this goal will require treatment without restrictions on severity of disease and a consistent ability to diagnose new cases even as prevalence decreases. Let me clarify what I mean by that. Right now, most of the people who are being treated are people with advanced hepatitis C in order to be able to prevent the complications from the disease. Those are not the people who primarily are the sources of passing the infection from person to person. With hepatitis C, unlike hepatitis B, we do not have a vaccine. You can't prevent the disease right now with a vaccine, but you can prevent the disease by curing it, and curing it in the people who would have passed it on to other people. That's a different population of patients who now aren't primarily being treated and need to be treated in order to be able to achieve our recommendations. The same levels of diagnosis and treatment would reduce mortality from hepatitis C in 2030 by 65% relative to 2015 and avert 29,000 deaths by 2030. Meeting these targets depends, assumed in this model is the treatment of about 260,000 people each year for hepatitis C. That's the level of treatment we are now achieving, but it could be increased, but our modeling assumed that it stayed level. That depends on diagnosing at least 110,000 cases a year until 2020, almost 89,000 a year between 2020 and 24, and over 70,000 each year between 2025 and 2030. Again, hepatitis C in the people who are likely to pass it on to other people is an asymptomatic disease. So finding these people and continuing to find them and being able to treat that many people each year will get harder and harder as we continue to successfully treat people with the disease. And that's why we make the point that we need to focus on treatment and on diagnosis in order to identify the people who need the treatment. We recommend a central coordinating office. Hepatitis elimination will require a coordinated action from various federal and state government agencies, and I'll show you some the recommendations accordingly. The leadership of a single office would help assure efficient and harmonious work. So our recommendation there is that the highest level of federal government should oversee a coordinated effort to manage viral hepatitis elimination. Moving on to the section on information. Not all state and local health departments are in a position to measure hepatitis disease burden. Much of it, as we alluded to, is asymptomatic, and people don't know that they have the disease. Diagnosing it is key. We think that an integrated, highly automated electronic surveillance system could go far toward a more accurate understanding of viral hepatitis disease burden. So our recommendation here to the CDC is that in partnership with state and local health departments, they should support standard hepatitis case finding measures and the follow-up monitoring and linkage to take care of all viral hepatitis cases that get reported through public health surveillance. CDC should also work with the National Cancer Institute to attach viral etiology to reports of liver cancer in its periodic national reports on cancer. National Cancer Institute maintains the SEER network, a nationwide network of reporting on cancer cases, and then based on that gives annual reports about the state of cancer in the U.S. But when reporting on liver cancer, they don't report on whether it's hepatitis associated or not. And adding that additional information in its periodic reports would be useful information to monitor the progress of the epidemic going forward. Other missing information, a better understanding of the epidemiology of viral hepatitis comes from research in high-risk populations. Such research can help clarify the true incidence and prevalence of hepatitis B and hepatitis C infection. So we recommended that CDC should support cross-sectional and cohort studies to measure hepatitis B and hepatitis C infection incidence and prevalence in high-risk populations. Moving on to essential interventions. Hepatitis B is vaccine preventable, but only about a quarter of adults older than age 19 are fully immunized. We don't do as well with hepatitis B as we do, for example, with flu vaccine in adults. So our recommendation is that states should expand access to adult hepatitis B vaccination, removing barriers to free immunization in pharmacies and other easily accessible settings. So, for example, there are states that allow pharmacies to give flu vaccine, but don't allow pharmacies to give hepatitis B vaccine. And barriers should be removed in state regulation in order to allow freer use of the vaccine. Early testing for hepatitis B viremia can help determine the best course of treatment for hepatitis antigen-positive pregnant women, balancing questions of drug resistance and hepatitis flare against the risk of mother-to-child transmission. Our recommendation is that the CDC, AASLD, IDSA, and ACOG, different specialty societies within the U.S., professional specialty societies, should recommend that all hepatitis B antigen-positive pregnant women have early prenatal hepatitis B virus DNA and liver enzyme tests to evaluate whether antiviral therapy is indicated for prophylaxis to eliminate mother-to-child transmission or for treatment of chronic active hepatitis. Again, continuing with essential interventions, the most effective way to prevent hepatitis C among people who inject drugs is to combine strategies that improve the safety of injection with those that treat the underlying addiction. People who inject drugs account for about 75% of new hepatitis C infections. Obviously, as the drug epidemic that the country is suffering from continues and worsens, this will make this even worse. So our recommendation is that states and federal agencies should expand access to syringe exchange and opioid agonist therapy in accessible venues. Continuing on, there are settings where screening could pay off handsomely, but screening can put a burden on the health system and providers. Society stands to benefit from any measure that sheds light on the subclinical burden of hepatitis B and hepatitis C infection. So our recommendation is that CDC should work with the states to identify settings appropriate for enhanced viral hepatitis testing based on expected prevalence. Curing hepatitis C has clinical benefit, including both reduction in cirrhosis and return to normal liver function. Treating everyone with hepatitis C, regardless of disease stage, would avert considerable suffering in patients. It would also protect society by reducing the population reservoir for infection. So it would reduce, this is an unusual situation where treating the disease would prevent the spread of the disease. So our recommendation is that public and private health plans should remove restrictions that are not medically indicated and offer direct-acting antivirals to all chronic hepatitis C patients. Again, that obviously has financial implications, and later in the report we describe a solution to that financially. Moving on to service delivery. So those are the essential interventions. How do we make sure they get to the people they need to get to? There are gaps between the practice of medicine as recommended by experts and what really happens, both here and elsewhere. NCQA, the National Council on Quality Assurance, I may have that name wrong, is interested in closing those gaps. The HEDIS indicators that they come up with command attention from providers and health plan managers. An inclusion of viral hepatitis screening in HEDIS would increase attention to these services. So our recommendation is that NCQA should establish measures to monitor compliance with viral hepatitis screening guidelines and with hepatitis B vaccine birth dose coverage, and include these new measures in HEDIS. Continuing on with service delivery, one of the main bottlenecks in hepatitis care is the need for patients to be treated by specialists. As a result, viral hepatitis care remains out of the reach for people in rural and underserved areas. So our recommendation is that AASLD and IDSA, the liver and infectious disease societies, should partner with primary care providers and their professional organizations to build capacity to treat hepatitis B and C in primary care. The program should set up referral systems for medically complex patients to make sure the complex patients get referred back to the specialists. Again, the service delivery, the people most affected by viral hepatitis can be hard to reach. People with the most serious need for health care, including people with behavioral health problems, need more support services. So our recommendation is that the Department of Health and Human Services should work with the states to build a comprehensive system of care and support for special populations with hepatitis B and C on the scale of the Ryan White system, which is designed for HIV treatments. Again, service delivery, incarcerated people bear a disproportionate burden of viral hepatitis. This is an opportunity. Jails and prisons are an ideal place to vaccinate against hepatitis B and to treat hepatitis C. On the other hand, if we don't do that, they're also an ideal place where the disease can be spread. So our recommendation is that the criminal justice system should screen, vaccinate, and treat hepatitis B and C in correctional facilities according to national clinical practice guidelines. Finally, or almost finally, financing. Eliminating hepatitis C in the United States depends on treating at least 260,000 patients a year with direct-acting antivirals. Yet none of these drugs will come off patent before 2029, 1 year before the target elimination date. Delaying mass treatment until then would result in tens of thousands of deaths and billions of dollars in wasted medical care costs. So we recommend that the federal government, on behalf of HHS, should purchase the rights to a direct-acting antiviral for use in neglected market segments, such as Medicaid, Indian Health Service, and prisons. This can be done through the licensing or assigning of a patent in a voluntary transaction with an innovator pharmaceutical company. Basically, we have a circumstance here where the drugs are very effective, but they're also costly. The good news is there are multiple of them available. And by having the federal government licensing rights to use the drug just in these limited populations that currently largely are not using the drug for reasons of cost, it does not undercut, in a completely voluntary transaction, it does not undercut the incentive for innovation inherent in our patent system nationwide. The companies continue to make the money they're making in the private system, but it will also provide substantial access to the drugs to people in Medicaid who currently aren't getting the drugs at all. Finally, research. There can be no elimination of viral hepatitis without better attention to research gaps. Mechanistic research questions that we propose include curative therapy for chronic hepatitis B infection and a vaccine for hepatitis C. Implementation research questions that we propose include stigma alleviation, understanding networks of drug users, and health in incarcerated patients. So finally, I'd like to thank my committee. The members are listed here, and the staff who are listed here and are around the table with us as well for the enormous amount of work they put in. I'd also like to thank our sponsors who gave us the opportunity to be able to make this contribution. Thank you.
Thank you. And for those of us who joined in late, just a reminder that you can now get the report as well as some other supporting materials along with this PowerPoint slide presentation at www.nationalacademies.org/hepatitis elimination. With that, we're going to open it up for questions. If anybody in the room would like to ask a question, I just ask that you please go to the podium and identify yourself and your organization before asking a question. You have a question here in the room?
Carl Schmidt, the AIDS Institute, congratulations on a great report. Looking forward to reading the details. Do have a question on the financing piece. And so has that been done before in the United States, purchasing the rights to a drug? And then also, would you have to change laws for this to happen, and also for Medicaid, the prison systems, and other systems to pay for it?
Yeah, sure.
Sure. Hi, I'm Niraj Sood. I'm a professor at USC and a committee member. So it hasn't been done in the U.S. before, but there is a section called Section 1498, which allows the government to take over a patent for a reasonable compensation. So that section has been invoked for things like night vision goggles by the Department of Defense, or for some banking software by the Department of Treasury. What we're proposing is a voluntary transaction, and we did, consult with legal scholars that it is legal, no laws need to be changed to do this. And we think this transaction benefits both the pharmaceutical company that makes the transaction, it benefits the government because it reduces overall costs, and it benefits patients in Medicaid and prisons because it increases access to the drug.
Any other questions from here in the room? Okay, with that, I'll go to our first question online from Donna Christensen. She asks the committee, are there any concerns or recommendations about tattooing and piercing as modes of possible transmission, or any other information you can provide?
Yeah, this is Brian Strom. We didn't actually go into that specifically. Clearly, the disease is known to be passed by injection drug use, but we didn't specifically look at that. The focus of the committee was on how to eliminate the disease as a public health problem in the U.S., rather than looking at what its underlying causes are, which are well understood.
Our next question is from Annette Gardner. She asks, what is roughly the financial cost to the government to purchase the license and patent?
Neeraj, maybe you want to go through the whole.
Sure. So we estimate that under the status quo, around 20,000 people in Medicaid and in prisons would be treated over the next 12 years. So if you look at the cost of treatment for Medicaid, that's roughly $40,000. That translates into $10 billion in revenues for pharmaceutical firms over the next 12 years in the Medicaid segment, or $10 billion in costs for the government, because it's the taxpayers who pay for Medicaid and healthcare provided in prisons. But there are 5 or 6 companies that compete in this market. So we estimate that each company is going to maybe make about $2 billion over the next 10 to 12 years. So if you offer a company $2 billion right now, it's a great deal for the company. So if you say, I'll give you $2 billion right now, but you have to ensure that the drugs can be distributed at cost to the Medicaid and prison population, it's a great deal for the government, because instead of spending $10 billion over 12 years, the government is spending $2 billion to buy the patent, and then we estimate roughly another $150 million to distribute the drugs to patients. So in that sense, from a societal or from the government perspective, it's a cost-saving thing, but the upfront cost is $2 billion.
Neeraj, you talked about 20,000 people being treated over the next 10 years, and that's out of how many?
So that's out of 700,000. So there is the Senate Finance Committee looked into this, and there were about 700,000 people in Medicaid and prisons who are eligible for treatment, and roughly less than 20,000 were treated.
Okay, and we're going to have a question here from the room.
Thank you. Good morning, Ryan Claridge, National Hepatitis Roundtable. Thank you for your leadership in putting the United States on the path towards elimination. Could you talk in a little more detail about your top-line recommendation of the federal government working at highest levels to develop and coordinate elimination? Are you looking at the establishment of a new office or in existing offices integrating?
Sure. This is Brian Strom. As we alluded to in the report, and as you saw as we went through the recommendations, there are recommendations for lots of different agencies, ranging from within the federal government, the states, CDC, and that requires coordination. In order for it to work well, requires coordination. Whether that coordination should be done within the White House by an existing group, by somebody else that's created, whether the White House wants to delegate it to somebody else, is not our place to tell them how they should organize. The point is it needs coordination at the highest levels of government.
Okay.
Sure.
Okay, our next question from online is from Eunice Itunu. What is the first step after being diagnosed with either hepatitis B or C?
No, I said this one.
Okay. This question is from Camilla Graham. So 50% of anti-hepatitis C reactive patients do not receive HCV RNA testing. What recommendations are made for affordable HCV testing?
She means the RNA. I wanted to ask her one about the RNA, affordable HCV RNA testing.
So this is Stuart Ray, Johns Hopkins. We did make a recommendation in the research section regarding the need for rapid diagnostic tests. They would provide a response to the problem of a step-off in the continuum of care where a significant fraction of people who test antibody positive do not receive an RNA test. We have another need through coordination that we would track with CDC the number of people diagnosed with antibody tests to ensure that those people do follow on with RNA tests, because that's clearly the next step in evaluating their need for treatment. So that gap needs to be closed, and that would be one of the priorities for any elimination campaign.
Thanks. Our next question comes from Jill Weschler. Would the government expect to negotiate licenses with all the manufacturers of the Hep C therapies, or just one or two? Have you had any response from manufacturers to this licensing proposal?
So the goal is to just license with one or two, because the more companies with which you license, the higher the cost of the licensing would be. And the evidence shows that these drugs have similar effectiveness. They all have similar rates of SVR or cure. So I think licensing with one or two would help save money. And in addition, once you license with one company, the prices of other products will come down because they will be competing with a much lower cost version of the drug. So in that sense, licensing with one company reduces prices for not just that company, but for other companies too. The report was just released, so I don't know what interest it would be from pharmaceutical firms.
Yeah, and just to follow up, Brian, just to follow up on that, all the companies would be offered the right to bid on this, and it is that bidding process that we think would on a purely voluntary basis, is that bidding process that we think that would get the estimate of $2 billion makes sense. It could well be much cheaper than that as you go through the bidding process. Companies could bid or not. They would all be offered the right to, and as Neeraj alluded to, in terms of companies' response, they haven't had an opportunity to respond since the report is in the process of being released as we speak.
Our next question comes from Martha Lofet. The hepatitis B vaccine is over 6 months or faster with Twinrix accelerated course. Is there thought to develop a one-injection vaccine? My concern is people who do not finish the course of 3 vaccines.
Sure.
This is Stuart Ray from Johns Hopkins. The research section of our report includes a recommendation that more convenient and effective hepatitis B vaccination strategies be developed. The 3 shots are highly effective, but many people don't complete the series, and a more convenient schedule would be helpful in achieving our goals.
I think the report also talked about, CDC sort of exploring more recommendations of a shorter interval vaccine schedule, or accelerated sort of 2-dose schedule. So that's also is something we've recommended CDC to look into.
And that was Dr. Samuel So.
Yes.
Our next question comes from Mark Looney. Could states implement the patent purchase option, or is that authority only legally an option for the federal government?
This is Neeraj Sood. So I think states could do it, but I'm not a legal scholar, but I think because in some sense companies routinely make these transactions. So a pharmaceutical company, if it wants to license a product from another pharmaceutical company, hundreds of these transactions happen. So I don't see why a state agency would not be able to do it. But again, I'm not familiar with states in the 50 different states to be 100% confident.
And just to clarify and follow up with these financing questions, realize the proposal is a win-win for everybody. It really gives the companies access to markets that they are selling very little in right now, without losing the markets that they're making a lot of money in now. So for the company who wins the license, they get a big win. For the public, of course, the public gets a massive win, because these are absolutely the key populations when you're talking about Medicaid and prisons, when you talk about hepatitis C, and they're mostly not getting treatment now. This ends up with treatment. But it does it in a way that is beneficial to the industry instead of harmful to industry, and so protecting the incentive for innovation in the future. I mean, these are great products, and we certainly wouldn't want to undercut industry's ability to be able to develop other products like that in the future.
Our next question comes from Colleen Flanagan. She asks, is there any work being done by NCQA to establish a hepatitis C measure?
The HEDIS.
Yeah, so is it being done now? Does anybody?
No.
I'm not aware.
As far as we know, there's no current.
Yeah, that is our recommendation, but that's the, we don't know of any such work underway now.
Okay. Our next question comes from Susan Lee. How do you see the role of the pharmacist change in order to support the elimination of hepatitis B and C?
When you went? Sure.
This is Grace Wong. I'm the family physician. Pharmacists are a really important part of the primary care team, and I think in the management of patients with both hepatitis B play an important role. I think there's also a role for them around vaccination. I think that's something for covers as well, so definitely.
And this is Trudy Maida from Johns Hopkins, also an important role with respect to syringe exchange for prevention of hepatitis B and C.
This is John Andrus from the Division of Vaccines and Immunization, the Center for Global Health, University of Colorado. A couple of questions referred to the vaccine, whether there's effort to develop new vaccines. But the challenge with the current vaccines we have is to increase coverage in those risk groups that Dr. Strom described. Successful childhood immunization is in place, but immunization coverage rates in adults and in risk groups have dropped off. So Dr. Wong's explanation of the role of pharmacists could greatly help with improving coverage in adults in particular.
Okay, our next question comes from Rachel McLean. She asked, what are the next steps for the Academy's report? Does it typically go to Congress, and does Congress typically issue a response of some kind?
Yeah, so this is Brian Strom. We actually presented it yesterday at HHS, and presented it as well at Congress to both the Senate and the House, as well as to our sponsors more broadly yesterday morning. One next step is obviously what we're doing now in terms of releasing the report, the press release that goes with it, the publicity that goes with it. There are a number of related follow-up presentations that we hope to have coming out in both medical and non-medical literature, reinforcing that. But beyond that, and the actual publication of the report itself, right now there's a preprint. The report itself will be out and available sometime this summer in formal publication process. The way the National Academies work is we as a committee disband after today. Our work does not continue. We were pulled together to go through these data, make these recommendations at the request of our sponsors, and you know, from this point forward, it is now the role of the sponsors or other interested parties to take it forward.
Thank you. Our next question comes from Matthew McLean. He asks, Recommendation 5.3 envisions partnerships between the federal government and states in a Ryan White program to reach populations in need of treatment. Does the panel endorse a major role for city health departments in such a scheme?
Yeah, yes. So let me back up, and this is Brian Strom. Let me back up and respond in a couple of ways. Firstly, to be clear, when we're talking about our recommendation for Ryan White, it was Ryan White or something, a program like that. Whether or not a new program is developed or not, Ryan White also represents an opportunity because it's obviously addressing the same population, and in fact, many people who are HIV infected have hepatitis B, hepatitis C. It would be a structure and an infrastructure that could well be taken going forward. We have many recommendations, going more specifically to your question, we have many recommendations in the report to CDC and to state health departments. Obviously, the way public health is organized in the U.S., in most states, there are then county health departments with or without city health departments, as the case may be. We did not drill down specifically to that level. That really is up to the state and how it organizes its health department. There are some states where there are lots of city health departments. There are others that have very few. And given the confederated structure of public health in the U.S., we certainly weren't making recommendations that some cities should do things and other cities not, or so on. We sort of left it at the level of CDC and state health departments.
With the elimination, our next question, comes from Mark Looney. He asks, with the elimination of polio in the U.S., Dr. Salk and Sabin donated the medicines for free and for federal nonprofit use. What is the potential for such donations for the 3 to be targeted groups, Medicaid, Native Americans, and incarcerated persons?
You know, we can't read the minds of pharmaceutical firms, but if you just look at the existing data, less than 1% of the prison population gets treated, and roughly 3% of the Medicaid population gets treated. So it clearly hasn't happened. And that's why we think a voluntary transaction where firms gain from the transaction as well as the government and patients is a good path forward.
Hey, this is Brian Strom. I also think it's important to repeat the comment that I made earlier, that these are tremendous products, and they really change. They do and will even more in the future hopefully make really important contributions to public health. The incentive for developing them for that innovation came from our capitalist system. You wouldn't want to undercut that. And so to expect the companies to donate it now, especially while it is still under patent in 2029, obviously we don't know the company's reactions to things because they haven't had an opportunity to comment, as we said before. But we wouldn't want to undercut the incentives of the pharmaceutical industry to develop other such major public health contributions in the future. It's why we sought to develop instead a solution where the companies actually make more money while the public health benefits in the process. So the federal government saves money, the companies make money, and we have a vast increase in treatment of the populations exactly at greatest risk who are not now getting that treatment.
And this was, I guess, inspired by the Vaccines for Children program, where the government does procure vaccines for underserved children. And you know, the program has existed for a long time, and there's no evidence that the program has hurt innovation. The program continues to buy new vaccines, which sometimes are fairly expensive.
This is John Andrus. To add to what was said, I agree. Having worked on polio eradication, the effort needs advocacy, needs other supportive interventions. A key model to that was the participation of Rotary International. So to incorporate a comprehensive strategy that will build on what Dr. Strom and others have mentioned will be vital, because usually those costs are not readily available, and going forward to get that kind of commitment, civil society engagement at all levels will greatly enhance the probability of this program being successful.
Thank you. Our next question comes from Amanda Conchafter. Do you have any current examples of prison systems successfully testing and treating inmates with hepatitis C?
There are some examples in Rhode Island, for example, successful testing and treatment. Sorry, Shruti Mehta from Johns Hopkins. There are some examples, but the vast majority have very low rates of treatment.
Okay. Our next question is patients who are hepatitis B core antibody positive do not need hepatitis B vaccines. Is there a plan to mandate anti-HBC testing when patients have HBV testing and enhance the algorithm of testing and linkage to care and education about reactivation risk?
This is Grace Wong. My understanding is the role of hepatitis B core testing is actually being looked at by CDC right now.
But again, to clarify, that's not our mission, and certainly we did not recommend that in our report. But obviously, the field will continues to change, will continue to change. It's a good thing, and CDC will continue to make recommendations that, as appropriate.
This is Stuart Ray. We also did recommend in the research section that be a topic of study because it's so important to address people at risk for reactivation, including people with malignancies who are being given, and autoimmune diseases who are being given treatment that suppresses immune responses.
Sam, so we did actually recommend CDC come up with the standardized guidelines as to, hepatitis serology that should be collected, including Hep B surface antigen, Hep B core antibody, and hepatitis B surface antibody.
Okay, our next question comes from Susan Lee. Are there grants available to help support HCV screening in the community setting?
So funding for hepatitis C, Shruti Mehta. Funding for hepatitis C has been challenging. There have been not as many resources allocated to research for hepatitis C that are commensurate with its potential impact. So there are some recommendations within the research setting specifically with respect to implementation of testing and treatment programs in the community. So there have been some efforts funded by the CDC and some recent NIH program announcements, but we need more.
I think, to follow on, I think the other challenge is those screening programs need to be coupled with the continuum of care so that positive screening results in positive action. That's been a gap that remains glaring in the treatment cascade for hepatitis C and for hepatitis B. We're hearing from practitioners in rural areas where there's an epidemic of opioid use and concomitant rises in incidence of hepatitis C, that screening for hepatitis C is ineffectual when there's no treatment available. That gap needs to be closed.
Okay, our next question on the internet. Is there any governmental support for chemical research for new direct-acting drugs against HCV that might produce new compounds at lower cost?
This is Stuart. There is ongoing research for new direct-acting agents. I think the efficacy of the current regimens is high, making it challenging to enter that market. But I'm sure that people would welcome treatments that, for instance, would result in shorter courses of therapy, and there are projects ongoing to look at shortening the course of treatment, and certainly increased competition could drive down costs. I think the primary motivation for this committee was to find a way to eliminate the problem, and increasing access to care, reducing the cost, or increasing the availability of treatment would be drivers for a successful campaign.
And just to clarify, the cost of these drugs available in the U.S. is not high because the production costs of the drugs are high. The costs are high because they have a patent of the drug. So, there's no problem to solve as far as the production costs of the drugs are concerned.
And that concludes our questions so far from the web. Does anybody in the room have any other questions? You can go to the podium, please.
Yes, my name is Yvonne Cameron from the Hepatitis Foundation International. We know that there is not a vaccine for hepatitis C, but do the recommendations deal with addressing this in the research component? Thank you.
This is Stuart Ray. Yes, this is an important question. One exciting opportunity that this report highlights is the possibility of eliminating a public health problem through treatment. That's an unprecedented plan because that's not been done with an epidemic infectious disease previously. We know that vaccines are the path to success historically in major epidemics. Initial efforts to develop the hepatitis C vaccine were focused on preventing infection, and our report outlines some of the opportunities, which include that we don't need to prevent hep C infection with a vaccine, we simply need to prevent chronic infection. A third of people who get infected with hepatitis C spontaneously clear the virus through immune responses, and we simply need to change that proportion to improve the outcome of infection, meaning that a vaccine would only need to increase the rate of spontaneous clearance. So that was a model that was not initially investigated when people were investigating a Hep C vaccine, and recent research data suggests that's possible. There's currently a randomized clinical trial of a vaccine candidate. We won't know the results of that trial for some time, but we think that it's a priority to develop a vaccine because in every case, epidemics have been best controlled with vaccines. But we hope that treatment will afford an opportunity to control this epidemic, even if a vaccine doesn't get developed.
Thank you. We have another question from the room.
Hi, it's Carl Schmidt again from the AIDS Institute. You can see that the drug pricing, the drug, access to the meds has gotten a lot of attention. I haven't read the report yet. Perhaps it's in there. When you talk about the price of the drug for Medicare, I think I saw that in the summary, and today for Medicaid, did you? Is it just the gross price, or do you consider the rebates? Because we hear that there's significant rebates, and so it's really hard to tell what is the actual price of the drug.
It's Neeraj from USC. So our estimate of the price includes some of the rebates, but the actual price that Medicaid pays is confidential. So we don't have access to the price. So the way we determined this was we looked at the financial statements of firms that sell these direct-acting agents, and in those financial statements, they report the number of patients they've sold it to and their revenues, and that gave us an estimate of what they were charging in general, and that was roughly $50,000. And we know Medicaid gets at least a 23% rebate of the price, so we estimate that Medicaid might be paying $40,000. But we haven't seen, we don't have access to the actual data which would tell us the exact price Medicaid was paying. And if you look at the list price for these drugs, they're much higher. They're at, the $80,000 range.
Any other questions from the room? Okay. I have another question from online from Catherine Ferguson. In terms of partnerships, what opportunities do you recommend for foundations and the charitable sector to contribute to the elimination of hepatitis B and C?
Yeah, I'm not sure we addressed that at all within our report. Obviously, there's lots of opportunities in principle ranging from drug costs to any of them assisting the states or federal government with any of the recommendations that were provided. But we did not specifically address the role of foundations.
This is Stuart Ray. I will comment that we know that these epidemics disproportionately affect the people with the least access to care, and there's major challenges with health equity. We know that community organizations and charitable groups can make a big difference in helping to close those sorts of gaps, and so we think that it's a very high priority that the access to care for people who currently have the least is an important component of any elimination campaign to be successful.
Any last questions from the room? Okay, and with that, that concludes today's public briefing. Thank you all for joining us, those in the room as well as those on the webinar. And again, thank you to the committee. As I said earlier, they all served pro bono, so really thanks for the opportunity for coming out today and answering your questions. And as a reminder, you can, again, the report as well as other materials online at www.nationalacademies.org/hepatitis elimination. Thank you.